This is very glad to see everybody here. First of all, I echo the other speakers, and it's just, it's really inspiring to see that we now have a cadre of healthcare professionals here that over the next 3 days are really going to delve into the depths and can take this back to your community, so that's key. So this is going to be something like speed dating through oxygen, because in 20 minutes it's really hard to determine which parts of this challenge to all of us we can attack. But I'm going to cover 3 main points to bring people up to date on some policy, and some of you have already heard this and actually are involved with me. Meeting the challenge of trying to match a device to the patient, which is getting increasingly difficult. And then lastly, really educating our patients in self-management, because in the long run, that's what will keep the patient well and also save some time on the clinic side, because as you heard from our previous speaker, you're busy chasing labs and dealing with the prior auths, and it's just too much to do. So briefly, around 2011, 2013, the Center for Medicare Services implemented what we call the competitive bidding contract. And I won't go into the details, but basically patients in a DME might have been previously covered with $250 a month that DME had, and that was basically cut in half to where patients, the DME now has about $125 or less dollars per month per patient to provide oxygen. So this nationally became a problem, and I'm involved, as some of you are in this room, with the American Thoracic Society, and this was brought up repeatedly, and we finally realized that we probably should delve into the problem. And we had no data, so there was a survey that we did, and that was published on just over 1,900 patients. This was through the Oxygen Working Group. And this survey, for the first time, really documented what patients reported as problems. And that was followed by an American Thoracic Society workshop group, which actually published formally more recommendations based on not just that data, but input from a multidisciplinary panel, which I will touch on again. And that brings us to really now, and the current status now is that the awareness is great. There are multiple foundations. Oxygen is very unique in that it crosses every age, every disease, and now has multiple advocates really working on Capitol Hill and trying to improve services to patients. And of course, I'm biased because we all work in ILD centers, we think our patients have even a greater need because they're high flow, and that really poses a unique challenge. So the results of the survey, and there is actually, just to highlight a few key findings, we did find that patients, overall about 50% of patients said they had problems. We did find that if they lived in a competitive bidding area, they reported more frequently having problems. We also found that the patients who reported problems in the past year were more frequently in the hospital or in an ER. So if they were if they were in a competitive bidding area, they more frequently were in a hospital, ER, or admission during the previous year. The other finding was that, guess who's educating our patients? Almost 70% are educated by the driver, the truck driver. Now, interestingly, they do a pretty good job. It didn't make much difference in terms of whether or not they had problems with the driver, but if a healthcare professional did, it was a significant decrease in patients reporting problems. And if they received no education, that difference became dramatic, and they had much more problem reporting in the previous year. And the problems, I don't need to tell you the problems, you all hear about these. The most common, which actually was a surprise, was malfunctioning equipment, which is pretty disappointing. And you can see the list: travel, delivery, lack of portables they can physically manage, lack of high flow, not enough tanks, can't change companies, big problem, incorrect or delayed orders, can't mix systems, can't have a POC plus some compressed gas tanks for portability. Liquid, we are very much involved in trying to advocate for those patients. So this was enlightening, and this is the group. So this, I really want to emphasize, we're all in our small populations each day, but there are many people working on this. This was our 8-hour workshop. I basically had all these people in a room with no windows for 8 hours. And we hammered out what are the problems based on the data we had, what are we going to do about it, what are the research gaps, where do we need data to move the needle. And this include American Thoracic Society, COPD Foundation, pulmonary hypertension, pulmonary fibrosis, Alpha-1, LAM, American Lung, physicians, nurses, patients were there. We had an NIH, FDA, DME, Apria was there, and we had CMS there. And she was in the room all day, very receptive, and could not believe what the issues that the clinicians were really seeing at the clinic level. So again, these are all of these societies, and in terms of advocacy, the kinds of activities that go on, and it is to being on the Hill and trying to educate our representatives. This is a letter that this group of advocates got together and drafted a statement and sent it to the director for CMS. And so that's the type of activity. And this was the letter. We're joining together, reporting problems, and the letter went on and documented data, the problems that we're seeing. And so that's the type of activity that goes on, because if the representatives in Congress don't have awareness of the problem, there is no action that will be taken. So awareness has been a big challenge. And this is just another sample. This came out from the COPD Foundation. Many of you may be aware that recently, nationally, there's activity of removing liquid from patients' homes by some DMEs. So this was brought to the attention again by lobbyists and our advocates. So we do now have a pause in competitive bidding. The PFF has really been a leader in this advocacy efforts and actually tried to gather some data pre and post pause. And right now we're really dealing with, we don't have respiratory therapists in the home, which is a huge loss because they used to be able to educate and test our patients. We don't have access to liquid. We haven't had liquid in California in our area for, I can't remember. I could ask our nurses over there. We don't remember having liquid. Every so often, someone will show up in clinic, and I actually took a picture because it's like we don't ever see it. So quality issues continue, and these advocacy efforts are continuing because of all these problems. This is the PFF, who took really a leadership role, and they sent out a survey to see what patients were doing before this pause in competitive bidding, and now they're resurveying patients. Their findings were pretty similar to ours, that 35% poor quality of service, high cost, insufficient flow rates, unreliable equipment, and travel. So the same themes are continuing, and they will continue to survey patients. I did spend a little time on the Hill. It's very enlightening, and I would urge all of you to tell your patients and yourselves, you can go to local town hall meetings when your representatives are in town. You don't need to travel to Capitol Hill, but it's very effective to have face-to-face discussions with our representatives. So moving along to the more clinical issue of trying to get that equipment to the patient, they're not all the same. So this is directly out of the newspaper. This is the direct marketing that goes on to many of our patients. This patient, if you're on a 1 or 2, 3 liters, and you can do pulse, you can have those cute little POCs, and you're fine. And you can hang out there for a couple of years. Our COPD and emphysema patients have a different disease trajectory. They're stable, and they can, not all. In general, they're more long-term, and they can have that. Our patients, we are very concerned with this marketing because it can happen without much physician input. The prescription can get signed, patient hasn't been tested, and it's very difficult to say to our patient, this might be okay now, but in 6 months you could be so much worse that it may not meet your needs. And that's hard to say to a patient, that you're going to progress. This is one of our patients coming in for her pre-transplant workup. She's got her day's supply, she's got like 9 tanks in there. And then this is a LAM patient who's a master's tennis player who fights with her DME regularly to give her enough tanks. It's the quality of life, it's exercise. She uses about 6 to 8 liters on her back. She changes between sets. She does her tank change and continues to be active. This is from the online Medicare booklet. So this is home oxygen, and this is our challenge because Medicare thinks you're at home on a couch with your banky and a cannula. So there's a lot of education that needs to be done, but this is from their brochure. This is home oxygen therapy, and this is what's there. So a lot of it, and I've talked to them on the phone, which is a challenge. They don't understand that we now, maybe it's our population, I want to say aging, but it's my population, that we are more active, and it applies to our patients as well. We see 65-year-olds with IPF that are professionals working, or their grandparents taking care of children, they're exercising, they're active, so they're not on the couch. So we also know that ILD patients are different compared to other diagnoses. In our survey, they were the lowest percent to use oxygen over 5 years, which speaks to the disease trajectory. And they also were the highest percent to use high flow. So that really confirmed our thoughts. We also know that they're different. This was a study that took baseline 6-minute walks at pulmonary rehab for COPD patients and ILD. And they all were matched. They had the same starting resting saturation. And they also matched them for PFTs. And look what happens when they exercise. This is the COPD desaturation incline or decline, and this is ILD. So we know our patients have a different desaturation curve. We know that clinically. We see that they can really drop dramatically, which also impacts their equipment. So when we look at how to match equipment, the low flow patient has a nice long list here. The medium, I would say medium to higher flow, the choices start getting fewer. Compressed gas, they can use an E-tank. M6, M9 won't last as long on continuous. They can use a larger POC, liquid if you can get it, or an E-tank. But then once you move into this category, the choices where we are is an E-tank, and that's it. So we've gone backwards. When I first did pulmonary rehab, many years ago, we had a big mother liquid tank. Everybody came on liquid. We could put them on 10 liters continuous. We filled their tanks. That's gone. The other issue is just portability. So an E-tank, it's about 10 kilos with a cart. And at 5 liters, it lasts about 2+ hours. But if we could put them on a liquid system, we're down to under 4 kilos and lasting 3.5 hours on the same liter flow. So that's what we're trying to educate lobbyists and CMS for. You know, it's not a high group of patients, but maybe we could get a higher dollar per month for those patients that need high flow and are mobile outside the home. So that's a challenge. This is a study looking at comparing. This is an ongoing education piece for nurses and patients that pulse dose is not liters per minute, and 2 on one is not equal to 2 on the other, and especially 5 on one is not. This actually looked at a POC on 6 compared to continuous flow at 5 and found they were equal on the 6-minute walk. But the patients have to be tested. We don't really see that as frequently. But the bottom line is that the patient has to be tested, especially if they're on a pulse system. So I need, Anne, I need you to write these letters, evidently. So, write with authority. I like that. That's a good term. So to get the patient equipment, and I will acknowledge that even with all of this done perfectly, the DME does not always offer what we need. So that's the bottom line. It's very sad. You can shop around DMEs before the patient commits. It's very challenging. It's time-consuming. If you want the perfect job description, I will point to our shout-out to Mary Ann. In our clinic, Mary Ann has the joy of doing all the prior auths for the antifibrotics, all of the pulmonary rehab orders, and all of the oxygen orders. So she's really the expert. Yeah, I know. We don't pay her enough. So the minimum is, and we've thought about using a template. The note has to document that they're hypoxemic, that you've done the 3 and 4 level testing, room air at rest, room air with exertion on oxygen, how much, and then put that in there. They have to now be documented that they're in a chronic stable state. So you have to also say what are failed therapies. Now, this is just idiotic, but as Anne says, give them what they want. So you can comb through that chart. If they were put on a bronchodilator, you can say failed previous bronchodilator. Because everybody comes with, I had asthma or I had COPD. Somebody gave a bronchodilator. So you can document that they failed bronchodilator, they've had breathing retraining and pulmonary rehab, they've had treatment in the past with X, Y, and Z, prednisone, Imuran, whatever. What other things can we treat them with? And they are still hypoxemic. So that documents that the patient has been optimally medically treated and has failed previous therapy and is still hypoxemic. And they have to be seen within 30 days of that testing. And this just drives our clinic nurses crazy. The patient leaves clinic, right? And they got a 6-minute walk upstairs, and we're looking at it, and oh my God, they need oxygen, and they didn't see a physician or a practitioner that day. So they have to come back. So the testing, the documentation has to be within 30 days of an face-to-face visit. So document, I would encourage this, the number of hours the patient's going to be out of the house, because you want portability. You can say that the patient cares for grandchildren, works, has pulmonary rehab, is undergoing a transplant workup, and is required to go to pulmonary rehab, whatever you can document, and that they've been tested. And this is a challenge, because in our clinic, we don't do the walks on pulse. If it's a new patient, we don't have a pulse to try them on. So if they're going to get a POC, you make sure that DME or somebody can test them on it to make sure it's adequate before they get it. That's challenging. We have a new problem that Mary Ann found. Patient gets prescribed an Inogen G3, and this could be any POC, I don't mean to be branding here, as their only piece of equipment for 24 hours a day, 7 days a week, exercise, rest, and sleep on pulse. And on the website says it is indicated for sleep. It's got this sensitivity. There's no documentation of overnight oximetry to confirm that this actually oxygenates that patient during the night. So that's a new red flag to us. ILD patients have a more shallow breathing pattern. So I would encourage you, if your patient is in that situation, that you demand or have someone order overnight oximetry. So that's a new wrinkle. And as Mary Ann pointed out, the patient is hauling this thing around all day at home. They have to carry it around instead of having a stationary concentrator with a long cord where they can walk. So I think this patient got a backpack finally. So this is like when you think you've seen issues, it continues to evolve. And then home fill units. We find that's a non-delivery model. So for DMEs, it does save them money. They're not going out delivering tanks every week. But these home fills, the patient has to fill the tank on top, and it takes time. So, and sometimes, depending on their stationary needs, they can't use their stationary unit adequately while it's filling their tank. It sits on top of it. So it's another challenge. And again, don't forget about using the oximeter cannulas. They're a nice conserving device for patients on high flow. So what recourse you have? It's difficult. Get Ann to write a letter. But if they're with a DME and their oxygen needs increase, you just need to document very carefully. And to file a Medicare Appeal. If that DME can no longer supply their needs, if you get a Medicare Appeal, they will allow the patient to change DMEs and start a new contract. But you have to go through the appeal process, which is not for the faint of heart. To be on that phone, just take about an hour and just commit to that. It's challenging. They're not supposed to be able to limit tanks. Again, you can file a complaint through their DME and Medicare. Patients should be given enough tanks that they need to meet their portability needs. If they don't have equipment, they're supposed to supply the same or equivalent item, which is difficult for high flow. And DME suppliers, there are standards that exist, including proof of beneficiary instruction and a complaint protocol, which means they're supposed to be trained. Okay, I have 12 seconds on educating patients, but I'm going to really just focus, that's all right, on my highlights at the end. We do know that it improves survival in patients with severe hypoxemia. We don't know that it does that for COPD patients with moderate or exertion only. And we lack, this is critical, we just don't have the data on patients who are okay at rest, but only desaturate with exertion. We just don't have that data. And I think I'm going to do that. And we know it's a big quality of life determinant. Breathlessness is a huge determinant. Starting oxygen is a critical turning point for these patients. And I would encourage you to read, Jeff Swigers has written some just outstanding reviews of this progression from the patient's perspective of going through the oxygen. And I would also want to say that it's important to manage expectations. It won't take all of their breathlessness away. It is a cumbersome therapy. There are issues, so it's important to educate them on all. I just want to highlight, in other countries, they don't get portable oxygen. Australia only gives it to you with exertion if you pass a blinded test using medical air compared to oxygen, and you have to document a % increase in your walk and in terms of feet. So it's not covered everywhere. We have to be aware that it's not a standard around the world to use it. Okay, so if all you do, and I am entrusting all of you now as ambassadors to go back and provide education. Out in the community and in many situations, there is no nurse, there is no educated MA, there are physicians overwhelmed with little resource. If all they did was handed the patient the link to that or the paper copy, that would be huge. So any of your referring physicians and patients, I would encourage you to get that information back to that physician. Okay, top 10 things patients should know. The pros and cons of oxygen therapy. I think that they should be given a checklist that this is what they should be discussed with them. That they need a prescription in writing for rest, exercise, and sleep. It is not based on how they feel. And how to titrate to migrate. Give them guidance where you want their saturations and when you want to be notified. That there are 3 forms of oxygen. What is the difference between pulse and continuous flow? And this is kind of getting into the minutiae, but POCs, even between themselves, vary in how they deliver oxygen. And there's a huge variability. And that they may not trigger the device adequately, especially with exertion. That the battery life depends on the flow rate, or the dose, the pulse dose, and the higher respiratory rate runs that battery out. They might outgrow their POC, as I mentioned, and the shop before they actually start a contract. Prevent nasal complications, no petroleum jelly, not only for their flammability, but as you mentioned, for, there's some fatty aspiration pneumonias that can happen. To try and decrease their flow rates at rest. We're working on technology so they can do this remotely. It's not there yet. And to make sure you humidify. Travel. We don't want to be called the day before they got on a plane. I need, a month before. Do they need testing? Do they need a letter? Do they need to rent equipment? Because Medicare does not pay for travel oxygen, as we all unfortunately know. Why they should attend pulmonary rehab. This is the best resource we have to help educate, exercise, and titrate related to oxygen. Always bring their portable equipment to clinic. You want to see what they're using, and in the perfect world, you'd want to test them on it. But at least you want to see it. And we have to let Medicare know when there's problems. This is the hardest thing to do in your clinic day. It takes forever. I believe Marianne actually went upstairs and met with one of our pre-transplant patients who was admitted and just hanging out waiting, for the call. She got on the phone, had a 3-way call, did the appeal. It takes forever. I mean, if you've done this call, for our patients to do it is very difficult. You'd have to really be their advocate. But it's the single most important thing to do because Medicare claims there is no problem. I shouldn't say that now. They used to. Now they were aware there's a problem. We need data because every call that goes in is taped and documented. So please be an advocate for your patients. I know it's impossible, but I urge them to call these numbers and work through it and support them. So these are our patients, trying to stay active. This is a drummer who's since been transplanted. Pretty inspirational, right? He's swimming with his oxygen, playing tennis, and this is I think he turned into an e-bike at some point, but he still was able to bike with his buddies and do his quality of life important things. This is just a list of publications and resources, and I would urge you, this seminar, webinar was taped, and it's available on the website. They had a very informative CMS and oxygen webinar recently. So thank you very much.